I'm Alex Lutz. Welcome to RUMC Vital Signs. On our show, you'll meet the fantastic people that make Richmond University Medical Center thrive. A full-service hospital located right here on Staten Island. You can find a full array of services by visiting www.rumcsi.org. As you can see, we're not in the studio today. We're actually at the Richmond County Savings Foundation Mother-Baby Unit located inside Richmond University Medical Center. Nearly 3,000 babies a year begin their journey in life right within these walls. Today, we're going to visit some of the facilities inside the unit, and we're going to meet many of the nurses and doctors that provide the care for our newborns, moms, and their support people. So we're here on our first stop in the mother-baby unit, and that is registration. And I'm joined by Jill Dawson, a nurse in our mother-baby unit here. So Jill, walk us through the registration process when mom first comes through the door.
Okay, well, when a mother comes here, this is her first stop. She's welcome to the unit. We take some demographics and insurance information. She fills out a couple consents regarding patient confidentiality and the HIPAA law. And then we walk back to triage for a full assessment.
Great. Now, I understand also that if mom comes in and there is a language barrier, that's really not a barrier.
No, we have language barriers quite often here. We are fully equipped with a couple different language options for us to get a qualified medical interpreter. And if that's not an option at the time the patient is present on the unit, we use our language line that has video and audio options.
Great. And I also see American Sign Language as one of the options.
Absolutely.
So when mom comes in, I'm assuming if she has her partner with her, the partner can come with her to triage?
Absolutely. You're allowed to have your partner come back with you to the triage area where we assess you for your admission to labor and delivery.
Great. Let's go to triage. So we're now in triage, and Jill has made the trip with us. So now that we're in triage, we're also joined by Carrie Ann Albanese, PA, here in the mother-baby unit. So Jill, mom is now here in triage. What are we going to do?
Okay, so first we're going to get her on the stretcher, put her on the monitor, the fetal heart monitor, where we're going to assess the fetal heart rate and the contraction pattern. We're also going to do a set of vital signs, take her blood pressure, her temperature, and we will get a tracing for about 15-20 minutes. Okay.
So what are we actually looking for?
Okay, so when we put her on the fetal heart monitor, we're looking at the fetal heart tracing, the contraction pattern, to see how close and consistent her contractions are, and we're assessing her pain levels.
So how do you make the determination that mom does need to be admitted?
Well, that's where PA Albanese comes in.
So when the patient arrives, at this point, the nurses have already done what they need to do, and by the time I come in, they're typically on the monitor for about 20 to 30 minutes so that we get a good assessment of what their contraction pattern looks like. Our nurses are really great about assessing their pain levels and getting us a lot sooner if they need to, but if they realize that the patient's comfortable enough, they'll get a nice, good, stable tracing before they call us. And then myself, physician assistant, or one of the residents will come in. We'll do a vaginal exam check. We will ask the patient a couple of questions, see if we need to rule out whether they've broken their water, whether they're experiencing any bleeding, or any other symptoms that might be related to their case. Once we have a full overview of what's going on with the patient, I'm then responsible for calling their private physician, assessing and telling them what the story is, and they will tell me what the further plan is.
And sometimes mom does not need to be admitted, it sounds like.
Correct.
Okay.
So if we determine that the mom is stable and she's not in labor, we'll give them good discharge instructions and follow-up instructions. We always make them aware that their doctor has been notified, because we won't make any decisions without their doctor's approval. So, for instance, we would say, your doctor is aware and would like to see you in the office as a follow-up on Friday. Just call the office and make an appointment. In the event that you go home and you feel any bleeding or any leaking, or your contractions become a lot more intolerable and you feel like you need pain medicine, then you should just call your doctor's office and head back in here. We're open 24/7. We're here all the time. So, if it's something that you think you can handle, you call your doctor. If not, you just come straight here as if you were going to the emergency room.
And how long is mom in this triage area if she's going to be admitted, roughly?
So no less than 20 to 30 minutes. But again, it also depends on, sometimes we just need to monitor them a little bit longer. Once the determination is made that we're going to admit them, the nurse and the physician or doctor team will work together to get the patient admitted. We put the orders in, the nurses will start their IVs. All of that stuff is done in this room, and once it's all done, we just wheel them and put them right up into the labor room.
And throughout her time in triage, her support person is with her at the entire time?
That's correct.
Great. So now we've made the determination that mom is actually going to be admitted. She is in labor. So our next stop is going to be one of the many delivery rooms here at Richmond University Medical Center. So we've come from registration and triage, and mom is now being admitted, ready to have her baby. We are here in one of the delivery rooms here at Richmond University Medical Center, and we're joined by registered nurse Tori Zammit and Director of Labor and Delivery, Dr. Marino Polisano. Thanks for joining us.
Thank you.
So I guess the first step is mom comes walking in. What is the first thing you do when mom walks through the door?
Well, we walk mom through the door, and the first thing we do is we definitely orient them to the room. We show them where the bathroom is, where everything else. We start showing them about the equipment. We also begin a health assessment, so we continue doing a health assessment through and through with the patient. We bring her to the room, we'll get her in the bed, and then we will put her on the monitor, which is right behind us here, and we'll turn this monitor on. There's 2 monitors that we have placed on the mom. One is to monitor the baby's fetal heart rate. The other one is to monitor the baby's contraction, the mom's contractions. Another thing that we can do with this monitor as well is we can monitor her vital signs through this monitor as well. We get the mom in the bed and we settle her in. We're constantly asking them about their pain, if they need any pain medication at this time. If not, we will continue assessing the patient through and through the labor as we continue to monitor her progress and the baby's well-being.
And that's actually an important question. Maybe it's a question for you, Dr. Polisano. A lot of moms, obviously, anesthesia or drugs are something they're looking for. Is there a time frame in which this can be administered, or can this be done at any point in the labor process?
Yeah, we believe in treating mom's pain whenever that may be. And both nursing and physicians are constantly assessing and reassessing mom's pain status, and then provide that woman the options that she has at that point in time for pain relief, be it something through the intravenous or be it an epidural if that's time. And to answer your question, there is no window per se, so there is no missed opportunity for an epidural. So when a woman is ready and prepared for it, then we go ahead and summon anesthesia.
Great. So mom is here, she's hooked up, she's ready to go. Walk us through the process by which you monitor the entire labor process right up until birth.
So, like I said, we monitor contractions, we monitor the baby's well-being, and the baby and the mom will let us know if they're feeling certain things. Sometimes on the monitor, we have all of our patients are in this fetal monitoring, and we can see sometimes the baby, we call it an early, looks like head compressions. So that may be a good sign that the baby is descending well into the canal, and it could be close to delivery. And sometimes the mom will tell us they're feeling a little bit of pressure down below in the perineum and in the rectal area. So it's different things that the mom and things that we assess through the monitoring that we can tell. But we basically are constantly looking at the patient, asking her how she's feeling. And then we'll call the doctor if we feel like the baby may be descending very nicely into the canal. We're collaborative here, so we're constantly in touch with our attendings, our residents, and they'll come in and examine the patient, and that's the best way to know is through an exam.
And Dr. Polisano, I imagine throughout the labor process you're checking in periodically on your patient. At what point in the process, if you see that something may need to be addressed, say an unscheduled cesarean, a breech, how do you determine that? How do you discuss that with the mom while she's in labor, and what are the steps to getting that procedure performed?
Something like a breech typically would be known beforehand. It's rare to have a laboring infant flip in labor. It does happen. If that were the case, it would be an urgent cesarean section. Otherwise, through monitoring of the labor process, we make the determination if a woman is proceeding well in labor, and we anticipate a vaginal delivery. However, if at any time a cesarean section becomes necessary, be it urgent or emergent, we are fully equipped to address those things. As the private physician, if I am present, I am constantly speaking to my patient and advising them of where we are in labor and what to expect. Managing a patient's expectations, I think, is very important from the beginning of the labor process, such that when and if a cesarean section is necessary, it's not necessarily a surprise to the patient.
I see. So now the baby's arrived. What are the first steps with our new arrival?
Well, the first steps with the new arrival, providing that everything is perfect, the baby will go immediately on skin to skin with mom. We are a baby friendly hospital, and we encourage and we will help the patient to bond with their baby as well as to initiate breastfeeding. So the first thing is baby comes out, the doctor, before they detach the baby, they do a little bit of
Delayed cord clamping.
delayed cord clamping. Sorry about that.
It's okay.
Which has been known to be very beneficial to the infant. And then immediately after that, the baby gets placed on mommy directly onto skin to skin to initiate bonding.
So the baby's been born. How long are mom and baby in this room before being transferred to maternity?
Mom and baby stay in this room provided it's a vaginal delivery for at least an hour to an hour and a half. We recover the mom while the baby stays in the room, and while we help her initiate with breastfeeding as well.
And we talked about the labor process and how we're monitoring mom, but we're also kind of helping her with her process. And one of our tools is this.
Yes.
What is this?
Yes, I like to call this a peanut for your peanut. So, and this is what I tell all our patients. We place this in between the mom's legs. This really helps in opening the pelvis and assisting in the baby descending into the canal successfully. And it works really, really well. So we will place the mom on either side, left or right side, and we will put this right in between her legs while supporting her back as well. And we do this every hour. We'll flip the mom from side to side to assist in the pelvis opening and the baby descending.
Wow.
So I know it looks funny, but it really
Looks like a peanut.
It works
looks like a
wonders.
peanut. Okay.
It works wonders. It's really a very, very good tool that we have here.
Well, thanks you both for joining with us today.
Thank you.
As you heard, there is a procedure called the cesarean section. And when that happens, mom is taken to the recovery unit here in the mother-baby unit. And we're going to visit that section next and give you an inside look at what goes on in that room. So mom's now had her bundle of joy, and we're now in the recovery room here in the mother-baby unit. I'm joined by Janine Miola, registered nurse here at RUMC, and Dr. Michael Kabad, the chair of OBGYN. Thanks for joining us today. So tell us a little bit about what the recovery room actually is.
Okay, so a patient will come in here after a C-section and they'll be monitored for 2 hours. And we'll set them up with a set of vital signs that will go off every 15 minutes. Okay. And we'll also check them for bleeding.
Okay. And Dr. Kabad, when you come in as the physician and you have a patient that's in recovery, what are you looking for?
I'm looking at the condition of the patient generally. My eyes go to the monitor. I evaluate that as I'm speaking to the patient to determine how well the patient is recovering after the surgery and to see how effective the pain medication that was administered to her during the surgery is taking hold. To make sure she's comfortable, stable, I speak to the nurse, I get information about the patient's status and any concerns that they may have about the patient's condition post-surgery.
So there is a chance that a mom can be here for beyond 2 hours.
Correct.
And through the entire time that she's here, her baby and her partners are here as well?
With her at all times, and so is her baby. After we do the initial vital signs, the first set, we will put the baby right on the skin to do skin to skin and start the breastfeeding process.
So we start that right away?
Yes.
Okay, great. And what are some of these monitors that we're looking at? What is that actually telling you? What is that actually showing you?
Well, it's an EKG monitor, a blood pressure monitor, and a pulse ox monitor.
Is the baby also hooked up to any monitors
No.
while they're here? No? Okay, they're just here to be here with mom.
Yes. And we'll
So
do
again,
a-
that bonding
we'll
experience.
do a baby temperature on the baby to make sure the temperature is correct.
And obviously being in a recovery room after having a C-section, whether it's their first child or it's another baby that they've had, it can be, I guess, maybe somewhat traumatic, I guess. But Dr. Kabad, how do you keep a mom comforted and knowing that everything's going okay?
Well, I mean, it's the communication that you have, the nurse has with the patient, it's the doctor once they leave the operating room. Generally, physicians will give them some reassurance as to the procedure, how the procedure went, that everything went routinely. Once they arrive in the recovery room, the nurse really plays a critical role in making sure that the patient is stable and continues to observe the patient to remain stable during the entire time that they're here. There's a level of exhilaration on the part of the patient that, you know, they're pretty excited. I mean, it's a long road, 9 months, arriving here at this point. Child is here. It's a very happy time. So we try to watch them very carefully and communicate the critical information to them to make them feel comfortable at every moment of time that they spend with us here.
That's fantastic. Thanks so much for joining us. We're going to be leaving here now. We're going to assume mom is okay and she's being transferred to the maternity unit. So we're going to be heading that way, and that's the next stop on our tour. So we're coming to near the end of our tour. We are now out of delivery, and we are now in one of the newly renovated rooms here at Richmond University Medical Center. It's one of our maternity suites. I'm joined by Fanya Balo and Victoria Orleman, and they're going to tell us a little bit about what moms and their newborns can expect when they arrive here. So when mom first comes through the door, tell us how you greet her.
So she'll come in and I'll introduce myself and our staff here on maternity, and then we'll help her, assist her into the bed, and we do a full body assessment. We'll clean her up, make her very comfortable, ask her if she has any questions. We explain our postpartum neonatal care book, and there's an app now that you can download, and you scan over the QR codes. Every page here has another video with more information, so I go through that and I explain that to them as well. And then we bring the baby in, and we'll help her with anything that she needs help with the baby as well.
Yeah. And as a new unit, what's some of the amenities that mom's going to be able to enjoy?
Well, we do have this big, beautiful bed that can come up and down just like any hospital bed. We have a refrigerator. They have their own refrigerator here. They get their own private bathroom over there, and a nice big TV for them to watch something, and they have the call bell, whatever they need.
And their support person can stay, correct?
Yes, their support person can stay overnight. They can sleep in the bed, or I tell them that this couch actually pulls out as well and can become a bed if they don't want to sleep in the same bed.
And how long does mom and baby usually stay before being discharged?
It depends on if the mom had a vaginal delivery or if it was a C-section. With a vaginal delivery, they usually just stay one night, stay overnight for at least 24 hours. And if it's
So while mom is here, the baby's at the bedside the entire time?
Yeah, so while mom is here, we do encourage mom to keep the baby here in the bassinet unless she is doing skin to skin or feeding or bonding. This bassinet's beautiful. It has a few drawers here, and this goes up and down, so it's easy for mom to see baby at the bedside. Yeah, and we help them with whatever they need help with while we're here.
And how long is mom and baby usually in the maternity suites?
It depends on if they have a vaginal delivery or if it's a C-section. For a vaginal delivery, they do stay for overnight, usually just for 24 hours. And then we'll run all of the tests on the baby at 24 hours, and then they can be discharged from there. With a C-section, they stay for 2 nights.
And so let's assume for the moment now that the moment's arrived and mom and baby and everyone's ready to go home. How do you prepare them for discharge?
So we make sure that baby is able to feed, whether it's breastfeeding or bottle feeding. We assist the parents with that. We just make sure that mom's questions are all answered, that she is medically approved to leave, and that the baby is medically approved to leave, and then we help them get going.
So Vicki, as we said at the beginning of this segment, this room is one of many that has just recently gone under a renovation. It's part of a larger project, right?
That is correct. So on the second floor, we have currently all private rooms. All rooms on the first and second floor have been completely renovated. There is a second phase to this project where we will be expanding additional patient rooms so that we can enable all individual private rooms. It is a matter of coordinating it with multiple projects within the hospital that RUMC is committed to.
So my understanding is even though that all these rooms are being converted into one-bed rooms, we're not losing any capacity at RUMC.
That is correct. We have the same capacity. And they all have the same amenities. They have individual refrigerators, they have the TV, for their use, which will also enable them to do video with their home, do FaceTime. There's an educational channel that the nurses use to help with education of the patient throughout their stay while they're here at RUMC.
Since 2008, RUMC has had the designation of being Staten Island's only baby-friendly hospital. Can you explain exactly what that is?
It's an internationally recognized designation by the World Health Organization and UNICEF. And there's a set of practices, a group of practices that a hospital has to comply with in order to be designated such. The bottom line is that it emphasizes education for all patients and that they can make an informed choice. So while we highly encourage breastfeeding as the best method of feeding, a mom is free to choose to feed her baby however she does. And depending on what she chooses, then we will teach her and her partner how to do that properly.
Well, thanks for joining us. Really appreciate it.
Thanks for having us.
Sometimes when a baby's born, they need a little bit of extra attention and care, and that's where we're going to go next. We're going to go to Richmond University Medical Center's Level 3 Neonatal Intensive Care Unit, otherwise known as the NICU. We're now joined by registered nurse Erica DeLuzio and Dr. Santosh Parab. We're going to be talking about Richmond University Medical Center's Neonatal Intensive Care Unit. Sometimes newborns need a little extra attention as they begin life's journey, and we're going to talk a little bit about the services provided in the NICU. Thank you for joining me.
Thank you.
Can you start by telling us a little about why a newborn would be admitted to the NICU?
Newborn baby who needs any extra help than what can be given in newborn nursery, like respiratory distress, feeding problem. These are the babies, along with the premature babies, are the ones who are admitted to the neonatal intensive care unit.
Mm-hmm. And as a nurse in the NICU, how are you monitoring the babies, caring for the babies?
All our babies are in something called the giraffe, which is right here, and they are they're on monitors. And if they need oxygen support, they're on the ventilators, which looks like this in our NICU. And we just continuously monitor them.
And how many babies does the NICU accommodate at the max capacity?
Maximum capacity of our NICU is 25 beds. So that is the normal number we can maximum go to.
And I can imagine that if parents have babies in the NICU, it can be stressful, it can be very nervous, nerve-wracking, and worrisome. You know, not only are you as physicians and nurses taking care of the newborns, how are you also making sure mom and dad are okay throughout this experience?
So whenever they're able to come up to the NICU, we encourage them to come up. They have to be cleared to be able to come up. We allow them to do family center care, is something it's called. We allow them to change the baby's diapers, help with feed-ins if it's the baby's able to get fed by the parents. We encourage them to ask any questions they have. There is no bad questions. They could ask. It is their baby. They're going home with the baby. So we just encourage them to keep asking questions and keep learning.
And doctor, I imagine it's very exciting for the staff and as well as obviously for mom and dad when a NICU baby is going to go home. How do you prepare mom and dad for that transition and discharge to going home?
Many times it's a nerve-wracking for the parents who are taking a baby who is a premature baby who is on multiple monitors in the NICU and going home. So we train parents in understanding what are the signs and symptoms they have to recognize without the use of the monitor. So this process starts well before the babies are going home. So mother is sitting with the baby, feeding the baby. Nurses train her what to watch for, what to look for when the baby is having any problem. Then before the baby goes home, baby has to do multiple things. One of them is maintaining temperature in the room air. Then parents need to learn how to change the diaper, change their clothes. All these things are taught by the nurses as the process towards the discharge is progressing.
So when a baby goes home, it doesn't end their relationship with the NICU. I understand there's a number of programs and services that we can provide to help not just the NICU baby, but also mom and dad as well?
Yes, there are multiple programs which are involved. One of them is the follow-up care for the babies, because many of our babies are at risk of developing developmental problems. So these babies are followed up when they are in the NICU by our speech therapy, occupational and physical therapy department. And after discharge also, these babies are followed up by them so that there is no gap between receiving the early intervention therapy which these babies need. And this is a program which is going on for a long time now. Other services we provide for the mothers who are screened for depression, anxiety, the mothers are referred for appropriate services so that even parents can get the appropriate services which are necessary.
And are you finding that a lot of mothers are depressed after childbirth?
It's especially it has increased after the COVID, so that has caused many mothers to be referred for any interventions which are necessary.
And roughly how many newborns do you care for in the NICU in a given year?
In a given year, we care for around 500 newborns who are admitted to the NICU. These are full-term as well as preterm.
Thank you so much for all that you are doing to take care of the babies in the NICU and here at Richmond University Medical Center. So this is the last stop on our tour here at the Mother Baby Unit at Richmond University Medical Center. So come and join me as we take our leave of the hospital and the Mother Baby Unit. An important part of being here at Richmond University Medical Center if you've given birth is educating moms about the importance of breastfeeding and breast milk. Richmond University Medical Center is happy to have Anna Moreno, a lactation educator, here on staff whose role is to do just that. Thanks for joining us, Anna.
Sure. Well,
Tell us a little bit about how you educate moms on breastfeeding and the importance of breast milk for the newborns.
Well, there are two different ways that at least I have access with the patients to be able to teach them. I do it virtually on a monthly basis where they'll be able to learn prenatally before they give birth, just to prepare them for the great event and once they have this little person in front of them. And then I do it on a one-to-one basis once they deliver.
Mm-hmm. And tell us a little bit about why breast milk and breastfeeding is so important for the health of a newborn.
Well, it's really critical. It's the thought process should be that it's human milk for the human baby. It's the most natural and the most well-balanced, nutritious milk for the baby. It's made specifically for the baby by its mother.
Mm-hmm. And I imagine that the education and teaching a mom how to breastfeed, you learn it here in the hospital, and then this is something that continues.
Yes, and onward. And even after they leave here, we do support them either by way of myself or one of our other lactation consultants that work on a per diem basis.
So you stay in touch?
Oh, yes.
So you stay in touch with a lot of the moms after
Yes.
they just, oh,
Yes.
that's fantastic.
Mm-hmm.
And my understanding is you have a very unique international accreditation?
Yes, International Board Certified Lactation Consultant.
Oh, what does that mean?
Oh, it's a whole lot of work involved in that. And yes, it is a prestigious certification that's deemed to specific individuals that go through a strenuous training to obtain that certification and an examination.
And was this something you wanted to do?
Yes, I did.
Why?
I guess when I started taking care of mothers and babies, it was amazing to see the look of these parents with this baby and not knowing what to do with them. And then with the mother who hoped to breastfeed and just couldn't, having all the difficulties, and me not knowing how to as a brand new nurse. So I immediately started delving into research on, how do I teach this mother this? And that's when I learned about this certification, and the rest is history. I just delved into it, and I was lucky enough to have a physician to back me up, to be able to guide me and lead me through that training.
Do you find that most moms are receptive to the idea of breastfeeding?
Most are, especially when they don't know much about it. We come from a generation that primarily bottle fed and not breastfeed and not know anything about it. So yes, especially this generation that's coming in, yes, they are very receptive and curious about it.
Mm-hmm. And I imagine this is something that you and most of the staff here are trained to provide that level of education?
The staff here are trained basically to assist the mothers, and especially if I'm not available, for them to get them started. And if there's any specific issue or problem, they call me in to try to assist in that situation.
And how long have you been here at RUMC?
9 years.
How long have you been a registered nurse?
36 years.
Wow. Well, thank you for all the...
And I've been an IBCLC for now 30 years.
Wow.
So.
Thank you for all that you're doing for so many people.
Sure.
If you'd like to learn more about the breastfeeding and breast education courses here at Richmond University Medical Center, you can visit the website at www.rumcsi.org. I want to take this opportunity to thank everyone that's appeared on today's show. As you can see, newborns, moms, and their support people are in great hands by coming to Richmond University Medical Center. RUMC has served the Staten Island community for nearly 120 years. You can help ensure that those services continue for generations to come by making a financial contribution to the hospital. To do so, you can visit www.rumcsi.org and click the donate button, or you can call 718-818-2106. That about does it for this episode of RUMC Vital Signs. I'm Alex Lutz.